Good afternoon, everyone. I am Dr. Abhijit. I am a fellow in geriatric oncology. I will be presenting a proposal titled as Geriatric Oncology Multi-Domain Intervention Study to prevent cognitive impairment among older Indian patients with cancer receiving chemotherapy, a phase 3 randomized controlled trial. So, cancer-related cognitive decline is an effect of cancer treatment on cognitive capacity, and cognitive problems have significant consequences, including loss of functional status, decision-making capacity, treatment compliance, as well as quality of life. So, multiple hypotheses are put forth about how chemotherapy drugs affect cognition, including chronic inflammation, hippocampal atrophy, reduction in the white matter and neurotransmitters, as well as reduction in the gray matter area. So, the prevalence of cognitive impairment prior to starting the chemo was found to be 30%, and it can increase up to 75% during chemotherapy. And among survivors who were surveyed, it was found that 75% of them self-reported cognitive symptoms, and 75% of them wished that they received some form of support, which included particularly cognitive training. So, cognitive training and physical exercises have shown benefit in preventing decline in at-risk older adults, as well as showing promising results in cancer-related cognitive decline as well. So, the hypothesis is a 3-month multi-domain intervention, which includes cognitive training, exercise, and mindfulness, will decrease chemotherapy-related cognitive decline at 3 months in older patients with cancer receiving chemotherapy compared to the usual care. So, the aim of the study is to establish the efficacy of a 3-month multi-domain intervention in preventing chemotherapy-related cognitive decline in older adults with cancer receiving chemotherapy compared to usual care. The primary objective is to investigate the effect of 3-month intervention on cognition by using the Adams-Brooks cognitive examination tree in older patients who are receiving chemotherapy. So, for secondary objective, we would like to see the change in their depressive symptoms using geriatric depression scale, functionality using CAT and Norton's activities of daily living, quality of life using Q&Q, as well as fact cognition, caregiver burden using direct burden interview, sleep quality using Pittsburgh Sleep Quality Index, progression-free survival, overall survival, as well as change in their vulnerability in domains of geriatric assessment. So, it will be a phase 3 interventional randomized controlled trial, and the patients age 60 years and above who are referred to geriatric oncology clinic will be screened, and those who are going to receive chemotherapy and who have an ECOG performance status of 0 to 2 will be included, whereas those who are having a pre-existing severe cognitive impairment and those who are deemed to be unfit to undergo a physical exercise regimen will be excluded. So, the randomization will be 1:1 ratio to intervention arm as well as control arm. They will be stratified for age, sex, ECOG performance status, and cognitive function at baseline. So, the patient's cognitive assessment will be done using the ACE3 Hindi version, which assesses domains including attention, memory, fluency, language, as well as visual spatial. The score is out of 100, and those between the score of 72 to 100 will be labeled as normal, and those between 61 to 71 as considered as having mild cognitive impairment. For the intervention part, the cognitive training will be done by a computer-based cognitive trainer, which is called Rehametrics. It helps in training different areas of cognitive function, including memory, attention, executive function, language, and visuomotor, and all tasks are sensor-based. So, it will be the training will be conducted 3 days a week, and the performance of each session will be updated. And during the next session, a higher level of task will be done. For physical intervention, we intend to include progressive resistance exercise as well as supervised aerobic exercise training for 3 days a week, and mindfulness will be used using a smartphone app or meditation for 10 minutes a day. So, this will be the flow of the study. Patients will be randomized into usual care arm and intervention arms, and at 3 months interval, we will assess for the outcomes. So, for sample size calculation, assuming a mean change in the ACE3 score in standard group of 15 points, and we hypothesize that the mean change in the ACE3 in intervention will be 10, with a standard deviation of 10, power of 90%, and alpha of 0.05, and estimating a dropout rate of 10%, we estimated our sample size to be 152. The data will be analyzed using SPSS. For the primary hypothesis testing, we will use test or man-between mean test, and the post-intervention ACE score will be described as mean with standard deviation. For secondary endpoint analysis for categorical variables, we will use chi-square test, and for continuous variables, we will use t-test or man-between mean test. The p-value less than 0.5 will be considered significant. Feasibility, patients attending our geriatric OPD in a year are roughly 600, and assuming a 25% recruitment of patients, time to recruitment would be 1 year, and infrastructure of our institute, specialized geriatric oncology working group committed to advance the care of older patients with cancer, physiotherapy and occupational therapy departments that are skilled at assessing as well as caring for older patients with cancer, and institutional ethics committee as well as data safety monitoring group. The impact at individual level would be decreasing the chemo-induced cognitive decline in these, which will help them maintain their functionality, which is meaningful. And at global level, between January 2019 to December 2021, around 30,000 patients aged more than 60 years with cancer had visited EMH, and globally it is predicted that 14 million of them of new cancers by the year 2035 will be among people above the age of 60, which will constitute for 60% of the global cancer incidence. Assuming that the intervention will prevent cognitive decline in 10% of the patients, we think that 3,000 patients in TMH will benefit, and possibly 1.4 million older patients with cancer globally will experience a decreased incidence of cognitive chemo-induced cognitive decline. And patients who do not experience this decline may have an improved functionality as well as quality of life. And the prevention of decline is one of the most important factors that will help older persons perform activities of daily living and maintaining their independence. Thank you.